So my due in the next few minutes is to tell you about dissatisfied multifocal IOL patients, what is to be the treatment guidelines for them. We do need to understand that it's no longer a common problem. The multifocal IOLs of the present day, be it Indian or imported, are doing extremely well, and there have been different studies which have told us, which are telling us today, 94% in the Concerto study and 98% in the Harmony study, and in recent US FDA study with all the latest IOLs, that there's a good majority of the patients want the multifocal IOL in the second eye. But then there are these reasons for a 6/6 unhappy patient, and we need to address each of them. We cannot get defensive. We need to ferret out the problems. We need to separate the problems. Is it some kind of a visual disturbance we treat differently? Is it that the patient has great vision for distance but not so for intermediate and near? We'll need to treat differently. Is it that the patient was seeing very well initially and later had a visual drop, which could be a PCO or similar, and we need to treat differently? So we need to look at the ocular surface, the dry eye status, the IOL centration, the PCO, the macula, the refraction. If it is a small refractive error, we could look at doing a PRK or a LASIK. PRK could be fine if the corneal thickness allows, the ocular surface is okay. But if a patient wants an immediate result, immediate effectivity is very complaining, you would end up doing a LASIK for him because you do not want him to be further disturbed with the healing response of a PRK. Again, PRK and LASIK may not help if the residual error is a hyperopic error, we need to think of putting in a piggyback lens, or the patient is really sitting on your head and is very unhappy, you would have to think of doing an IOL exchange. And if it is an IOL exchange and you know that there is no other cause for the visual disturbance, then please do not delay removing it, because the more the fibrosis, greater the challenge. But it is easier to cut a hydrophilic as against a hydrophobic. Sometimes you could even leave the haptics in the capsular bag and then take out the optic and position another lens. Not showing the video. Again, if you're going to put a piggyback lens in a hyperope, you need to choose a large optic. We have Sulcoflex lenses, we have the AIOC lenses, we have the different companies, Indian companies, which have come forward, but they have a posterior curvature on this lens so that you have a space between the primary lens and this lens, and the undulating haptics ensures it sits well, and we do have Nicham's nomogram, wherein in the myopic residual error, the same power can be put. For a hyperopia, you need to multiply it by 1.5. We need to look at the vault. Now, if it is a toric IOL which is sitting there and it is bothering, then we could go use the Barrett treatment formula or the schematifix.com, decide whether you're going to do bioptics for this patient, or whether you're going to rotate the IOL of this patient, or whether you're going to do an IOL exchange, and it tells you and you follow it accordingly. But if you're doing a toric rotation, sometimes in a high myope, you would want to put a CTR2 because these capsular bags are larger bags. But when you know in spite of it you're going to have a residual, might as well do a laser vision correction right away rather than doing mix and match. So anyway, if the first eye is going wrong, please slow down for the second eye, and you could consider a blended vision. Like in this particular patient, the patient underwent a symphony multifocal in one eye, was not happy for the near vision. You could go ahead and do a micro mono vision for this particular patient and place a symphony with a 0.75 under correction. And in this particular patient was so unhappy with the near eye, so we had to do a Technis +4 for him in the other eye, and the patient actually turned happy. I made a mistake here, and in this particular patient, the first eye was a symphony, but the patient had great intermediate vision, but was not happy with the near vision, and we went ahead and did a micro monovision and targeted for 0.75 myopia in the other eye, and the patient did well. And here the patient had a significant near vision difficulty, and in fact we had to change it from in focus and put an acrylic lens, and that seemed to take care of the problem. So there are different ways that we need to address this. You need to look at the ocular surface. We need to understand dry eye cannot be ignored. It could be preoperative, which you have missed, or it could be caused intraoperatively. If it has been caused intraoperatively, initially there was no dry eye, then treat him with anti-inflammatory lubricants. If there is a meibomian gland dysfunction, do the lid hygiene, the warm compresses, and whatever which you can. Have this kind of a figure to show your patient that you have a meibomian gland disease which needs to be treated. If it is a capsular bag, there's a PCO, don't hit it right away. Be sure that there's no other cause, only PCO which is disturbing, because you can't do an IOL exchange if you have gone and done a YAG capsulotomy. So wait for at least 3 months. Be sure that the macula is all right. There's no pathology which has got missed out there, and then go ahead. If the IOL is not centered, you never know, a patient has come from elsewhere, the haptic might have been broken. You need to ensure, but nowadays the newer premium lenses have a large optic zone. So even if you have an angle alpha which is more than 0.5 or even 0.8, it is quite forgiving. So keep this in mind. And this was a patient who came with decentration. He needed a toric IOL rotation, but he also had a small area of zonular weakness, and by placing a CTR and a toric IOL rotation, we could sort him out. These are the various kinds of macular problems which you need to refer to your retina person. When you talk of visual disturbance, it could be a positive dysphotopsia, negative dysphotopsia. Positive dysphotopsia and negative dysphotopsia are largely because of the modern square edge lenses and the high refractive index of these lenses. But neural adaptation sorts most of these cases, and lots of reassurances. Invariably they are all right. Rarely they need an exchange. But in negative dysphotopsia, which again is because of the refraction of light from the edge and the posterior surface going in different directions, a Lambertian light scatter occurs. And in this particular case, you could rarely try a sulcus placement of a 0 power piggyback IOL, or a reverse optic capture could be tried. And most importantly, you need to choose the right patient. You need to explain to the patient. You need to keep the thought of IOL exchange as one of the options. But I think planning before, well in advance, is best for this patient. You have a range of lenses, and even if the patient has little residual error, if he is a happy patient, don't go after it for your level of perfection. Let him be, because he is a happy patient anyway, and that's all that matters. Thank you very much. There are more slides, but I wanted us to all go back thinking that we need to have a conceptualized approach open to the challenges, and we would have treated most of these dissatisfied multifocal IOL patients.